prolapse patient, there's this billow. That's the click. It is exactly the same physics of a sail that fills with the wind, and you can hear that sail snap, right? That's what the click is of mitral valve prolapse. Now, in this particular patient, there's the click, but the valve is still competent. It doesn't leak. Hence, there is no murmur in this particular patient. What about if there was both the click, but also, after this redundant valve fills out here, there was leak because the valve did not do its job? Well, that would be a click and a murmur. So there's the click, and then between the click and the second heart sound, there's a murmur. You can plainly hear it here. Right, so let's go back and turn off the murmur. Turn it back on. Now that's not a very loud murmur, but part of the reason may be that where your stethoscope is may not be right where the murmur is best transmitted. But also, you can affect the loudness of the murmur. And one of the cases I presented to you was an attempt to see whether you understood that point. So there only are two common murmurs that increase in intensity when you make the heart smaller. Why would it be that mitral prolapse is one of those? Well, here we have this billowing valve. If you made the left heart smaller, by whatever means, you could phlebotomize the person and take a liter of blood out of them. That would make them smaller. Or you could just have them bear down, right, to trap blood in the periphery. Or you could have them stand up, so temporarily there's blood that's trapped down in the leg veins before it understands that it needs to shift it back to simple circulation. But if you do that, and you make this heart smaller, then these lax valve leaflets and chordate tendini would allow a greater amount of leak. So one of the cardinal findings of mitral prolapse is that the murmur gets worse when the person does Valsalva maneuver or stands up, or you do anything else that makes this heart small. Okay? What's the other murmur that gets louder when you make the heart smaller? It's the murmur of hypertrophic cardiomyopathy. For a little different reason. If you had too much muscle here, creating outflow turbulence gradient, when you make the heart smaller, that gradient gets greater. So a cardinal finding of hypertrophic cardiomyopathy that distinguishes it from aortic stenosis is the person bears down and the murmur gets louder. If you bear down and the murmur gets softer, because you're trapping blood in the legs, there's less blood flowing, that means it's aortic stenosis, not hypertrophic cardiomyopathy. In this case, this is a quick murmur mitral prolapse. Now let's do that here in a person with prolapse and exemplify how the murmur changes if you have them do maneuvers. So listen to the murmur here. Now he's valsalving. The heart's beating up. The murmur's loud. Now he's going to take a breath. Listen to the murmur. It almost went away. That characteristic finding will tell you right away that the murmur is now, it's not aortic stenosis, stenosis, etc. You just made the diagnosis by having the person do that. You could also do it by having them stand and squat, so it's more laborious. But let's listen to the murmur here. Very subtle. Now he's transfusing blood back. Listen to him. There's almost no murmur. Why did the murmur go away? Because you made the heart bigger by transfusing blood to the legs. Now he stands, the murmur's going to come back. And there it is. Now that was prolapse. Listen to this murmur. Sounds totally different. This sounds like somebody is sawing wood in the chest. And this is because if you look at the valve here, this is a broken valve, right? A flailed valve. This might be endocarditis, it might be the person just ruptured aortic, could even be a myocardial infarction, ruptured papillary muscle. But notice, unlike the case before, where the murmur didn't start until later during systole, this murmur starts right at the first heart sound. As soon as the heart starts ejecting blood, blood goes back into the left atrium, creating this harsh, early systolic murmur. This unfortunate person would actually present with pulmonary edema. And the reason is because even though maybe only half the blood volume from the ventricles going back into the atrium, if you look at this cartoon, the atrium, because this is acute regurgitation, the atrium cannot accommodate that blood. So it gets transmitted back to the lungs to create pulmonary edema. And that's exemplified by these pressure tracings down here, where these very large, in the dark is the left atrial pressure, a huge pressure that comes with this leaky valve transmitting blood back into the atrium. Now listen to this next murmur, which is the same situation, but years into the course. Same disease, slightly different character, lasts all through systole. And that's because the atrium here, look at how it can expand to accommodate. This is chronic mitral regurg. The person's made it through the initial stage. Now the leak can be accommodated because the atrium is compliant and will accept that regurgitant fraction, even though the valve, as you can see in this cartoon, is still flipping around here as a broken valve. So this is one of the more common reasons that you're going to hear systolic murmurs, mitral regurgitation. And in that particular case, this was their x-ray before. This is while they had acute mitral regurgitation, and then the valve was repaired. You see the heart size came down. In that case, that heart size was due to the atrium actually getting smaller. Now, I mentioned a moment ago that it depends where you put your stethoscope, right? So if you look at our little cartoon over here, classically, the aortic murmurs are heard over the aortic valve, right? So that would be the right upper and left upper sternal border. The mitral valve, you may not even hear up there, because the mitral valve is over here. So the base of the heart and the apex of the heart, and maybe not depicted here, way out into the axilla, would be the places to listen to the mitral valve. That's why if you put your stethoscope only on one spot, you are never going to be able to hear the murmurs that are there. So here's a gentleman with severe MR. We're listening in the aortic area. Listen to this murmur here. Unimpressive. Let's move the stethoscope. Much clearer. All you've done is moved a few inches. But some murmur sounds, particularly low-frequency murmur sounds, do not transmit very well. Therefore, you may not hear them, and particularly the right upper sternal border. Most of the time, you can't hear mitral regurgitation at all. Let's see if we can hear it out of the apex. Much louder. In fact, one way you can gauge how bad the mitral regurgitation is to gauge how far it goes. So if you can hear it at the apex, you can hear it in the axilla, you can hear it in the back, underneath the left scapula, that tells you the person has severe mitral regurgitation. And you can see on the little photocardiogram here, this is a pansystolic murmur. It's quite loud. No one here would miss that there's a murmur. I hear these people every day. They're sent to me, and I look at the last note of somebody else that says, no murmur. No murmur. Well, maybe they only listened up here. Okay? I'll give them the benefit of the doubt. But you might miss that one. So please, at least if you're going to listen to an adult patient, listen in the aortic region, which is up high, and then down toward the apex, because you will not be able to hear all these murmurs from any one spot. Now, why do people get mitral regurgitation? Most murmurs that I hear these days are mitral regurgitation, but most of the time it's not prolapse. In a younger person, it would be prolapse, perhaps collapse, but as the population ages, most of the time it's either wear and tear on the valve, calcification of the annulus, or in a heart failure population, as the heart gets larger, the structure of the valve starts to pull apart, and we call that functional mitral regurgitation, and it's the most common reason for regurgitation. It's just the leaflets don't coapt anymore because they've been pulled apart. No different than if you pull the door jamb apart, the door won't work appropriately. So that's the most common reason that we see it these days. Mitral stenosis, we don't see much anymore here. We're looking at the atrium. The blood has to go through. Here's the mitral orifice. And this is all scarred from rheumatic fever. All the blood that would normally flow through this, which is a couple of centimeters, have to flow through this small area about the size of a pencil. And that is classic for mitral stenosis. It's not something we see very much anymore. But here's what it sounds like, just so you can listen to it. Now, the important thing to recognize, this is a diastolic murmur. Systolic murmurs can be normal. Pregnant women, young, 15-year-old kids. Diastolic murmurs are never normal. Never. There is nothing that goes on in the heart that should ever lead to a diastolic murmur unless there's pathology. And here is the classic rumble of mitral stenosis. In fact, there's even an extra sound if you're listening closely, which is the mitral valve opening there. I'm not going to belabor this. You can spend your own time on this because this is something most of you won't be encountering very frequently. Instead, what you're going to hear if you have a geriatric population is aortic valve disease too, right? Because normally the aortic valve lasts about 85 years. And if I went to a nursing home in town and just listened, 100% of people in their 90s have murmurs. It's just random. And the reason is because the valve becomes thickened or sclerotic, as we call it. And then as that progresses, because once the valve becomes abnormal, believe it or not, bone genes get turned on in the tissues here. So what happens is these humps of calcium are bone. And you can actually look and see that there are osteoblasts in there. This is bone forming in a place that bone should form. So no surprise, if you form bone in these 3 aortic valve leaflets, that leaflet is not going to work very well. So let's listen to aortic valves, and this is the most common reason to have in the geriatric population, a systolic murmur. Now here we're listening at the apex. If you only put your stethoscope at the apex, here's what you're going to hear. Let's move it up to the aortic area. Same patient, 10 seconds apart. Now, what does that tell me? Well, if I'm listening at the right upper sternal border and I hear this murmur, that's a grade 3 or 4 murmur. And then I move to the apex, barely hear a murmur. Is this mitral regurg? No, right? This is aortic outflow murmur. So it's aortic stenosis or something else that causes an aortic outflow murmur. In a person with this murmur at the right upper sternal border, okay, there are only 2 things that cause that in an older person. It's either going to be calcific aortic stenosis or it's going to be hypertrophic cardiomyopathy. How do you distinguish the 2? You have them stop breathing, tighten up your stomach, and you listen. This murmur, if it goes away during that, it's aortic stenosis. If it gets louder during that maneuver, it's hypertrophic cardiomyopathy. So let's turn the murmur off just so that you can instill this in your brain. Now here's the S. Okay. Excuse that. So again, I would implore you to walk through these because you can put your stethoscope in this computer program in each of these places and listen how the murmur sounds different. But the upper sternum is where you're going to hear the aortic stenosis. Down at the apex is where you're going to hear mitral regurgitation and mitral stenosis if it happens to be there. And lastly, let's talk about aortic regurgitation. Okay, let's look at this woman's neck. You see an impulse up here that you would never normally see. Okay? This impulse, however, is a single impulse. Right? So how do I know this isn't jugular? Because it doesn't have an undulatory diastolic murmur here. This person has aortic regurgitation. When you hear a diastolic murmur in an adult who hasn't immigrated from some third world country, the vast majority of the time it's aortic regurgitation, right? Because we don't hear mitral stenosis very much anymore in America. But aortic regurgitation, much more commonplace. Here's the murmur. It's very subtle. Right after the second heart sound, you hear a decrescendo murmur, so listen carefully. Let's move our stethoscope and see if we can hear it somewhere else. So here you hear an aortic outflow murmur. You don't really hear diastolic murmur. Let's go to the apex. Outflow, no diastolic. Let's go to the left sternal border. Subtle. Diastolic murmurs are hard to hear. They're the most common murmurs that are missed. But they're the most important because, as I mentioned, they always indicate pathology. Okay. So let's go back to the slides. All of what I just showed you and more is on the website that the Criley's put together for. And this was a teaching tool for the UCLA residents and cardiology fellows. It's open to public use. It's a tremendous resource. Heartsounds.org. So let's go back to our cases. And then we're going to compare your vote. So here's this 23-year-old, remember her? She's 6 feet tall, volleyball player. She comes in saying, I'm aware of my heartbeat. And you heard a decrescendo diastolic murmur in the left sternal border. You also noticed that her fingers were longer than a normal person. So what do you think the diagnosis is? Choose one of these. Anxiety, hypertrophic cardiomyopathy, prolapse, dilated ascending aortic root, or rheumatic heart disease. Please choose one. Okay. So let's look and see what we've heard here. First of all, obviously young people can be anxious. However, anxiety won't cause a murmur, right? It might cause a little outflow murmur if they're tachycardic and hyperthyroid and anxious, like a pregnant woman would have an outflow murmur just due to hyperdynamic flow. But it would never cause a diastolic murmur. A diastolic murmur is between cardiac contraction, right? Hypertrophic cardiomyopathy, number 2, is a systolic murmur. So right away, if she has a diastolic murmur, you know it's not hypertrophic cardiomyopathy. Mitral prolapse, which certainly could occur in a 6-foot woman, right? I already mentioned Marfanoid-type women, mitral prolapse, men too. That could be it, except mitral prolapse would cause a systolic murmur. So the correct diagnosis is the diastolic murmur due to one of 2 things. Is it rheumatic heart disease, which would be mitral stenosis, or is it aortic regurg, as would be seen in a dilated ascending aorta? This woman can compete in competitive sports. I can guarantee you people with severe mitral stenosis wouldn't be doing competitive volleyball. She's 6 feet tall, she has elongated fingers, and she has a diastolic murmur in the aortic region. She has aortic regurgitation. The most likely diagnosis in a tall young woman with aortic regurgitation is that she has a dilated aorta. And 31% of you got it. Congratulations on that. So what would we do for this lady? She has palpitations, but she has an aortic regurgitation murmur. We think she has a dilated aortic root. Do you think we, A, would do no further testing? Should you order an echo, a magnetic resonance angiogram, or a CT, or genetic testing? Please choose one as the best answer. Okay, and I would absolutely agree with 2/3 of you. First of all, an aortic regurgitation murmur should always be looked at with some other modality. A little flow murmur you can ignore in, for example, pregnant women. That's a total waste of money. But a diastolic murmur should never be ignored. So what's the test? You could use either 2, 3, or 4. Turns out for 5, there is genetic testing for Marfan's. It costs about $300 now. That's down from $3,000 2 years ago. However, it's not useful in your management other than for genetic counseling if she wants to have a child, perhaps. So it's between 2, 3, and 4. Now the problems with number 4 is the radiation exposure. And we're not really looking at the pulmonary artery, we're looking at the aorta. You can get a CT angiogram, terrific test, but it's a significant radiation exposure to a 1 in 20s. So the best test would be 2 or 3, and for cost reasons and for really elucidating the magnitude of aortic recurrence, number 2 is the clear winner. So echo for sure. Okay, let's go back now to our other case. 81-year-old short of breath man, right, with hypertension and an abnormal EKG. And he has an outflow murmur over the precordium. It's pretty loud, grade 3, systolic murmur. And it increases when he bears down with the Valsalva maneuver. He has a little heart failure. His neck veins are elevated. He has a patajugular reflux. What's the most likely diagnosis for this man? Has he had a prior MI? Has he had just hypertensive heart disease? Is this mitral regurg? Is it aortic stenosis or hypertrophic cardiomyopathy? Choose one of those. And most of you chose aortic stenosis, so you'd be correct, and I'm glad the correct answer here is 5, right? So it's what I told you, that aortic stenosis murmurs will either decrease or might stay the same during a Valsalva maneuver. So the only ones that get louder with Valsalva, remember, mitral prolapse, which would not cause the findings in this guy of the T-wave inversions, or hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy in the elderly, different disease than in the 18-year-old high school football player. But that's a common issue in terms of systolic murmurs these days. And the tip-off is that EKG, big, deep E-wave inversions, murmur in the aortic area that gets louder when he bears down. This is hypertrophic cardiomyopathy. And would you therefore recommend nothing, an echo, a treadmill test, a CT angiogram, or cardiac cath? Choose one of these. And a lot like we mentioned before, and I agree with you, the echo would be able to quantitate the degree of hypertrophy. There's no indication in him to do CT or cardiac cath at this juncture. So in closing,